during our half day on the concepts of CBME, EPA and milestones, feedback and coaching, and to discuss how we're going to use the CBME website and McMap. We're essentially going to just discuss over here how we're going to complete our EPA assessments, which is a new change in our curriculum. And then future resident development sessions would include information on information and discussion on how the competence committee will be developed and how that would be part of your ongoing curriculum and assessments, as well as the concept of the academic coach. So just to discuss CBME, we all are familiar with ChenMed's roles: professional communicator, medical expert, collaborator, scholar, leader, health advocate, and we know the competencies associated with each of those roles. Essentially, now the term that we're using is we will be using is an entrustable professional activity. It's which is defined as a key task of a discipline, that is a specialty or subspecialty that an individual can be trusted to perform in a given healthcare context once sufficient competence has been demonstrated. So an EPA would be a workplace assessment where you would be either be directly observed, that is at the patient's bedside, or indirectly observed using a chart review or a clinical case presentation, and doesn't have to be at the patient bedside, or it could also use simulation, which would be considered a direct observation. Essentially, when you are being observed on an entrustable professional activity, you are being observed in the workplace, and then there are milestones that are used to construct the entrustable professional activity, and that is an observable marker of an individual's ability. So these milestones are then mapped to the ChenMed roles that we saw before. So an example would be where an EPA that we are seeing over here is an acute resuscitation of an unstable patient, which would be one of the Cbme-Epas, and the milestones that would be associated under medical expert would be assessing the patient's medical record and selecting proper investigations, prioritizing management, and under communicator, it could be team communication involving allied health professionals, talking to patient and family, and collaborating with other consultations services. So in terms of an EPA, essentially your supervisor or supervisor or assessor, when they are observing you performing an entrustable professional activity, they're assessing you on whether they can trust you on that EPA or not. And you are then scored on an entrustability scale of 1 to 5, which usually ranges from 1, where you could not or perform on the EPA, and the attending or the supervisor had to completely take over. So for example, in a resuscitation, an attending just walks in and takes over the code because you're not able to perform. Or it could be a 1 where they have to talk you through it, but you're able to do somewhat with guidance. Or a 2 where they have to prompt you, but you're able to do most of it on your own. Or a 4 where they can trust you to do it on your own, but they are there just as a backup. And 5 is where they trust you completely and they know that you do not have to be there. So if you think about an entrustability scale, it essentially is not giving you a satisfactory pass or fail. It essentially is based on the attending or your assessor's ability to trust you on doing that EPA on your own, and you're essentially given a score on that entrustability scale based on that assessment by the attending. So different EPA levels are transition to discipline, foundations of discipline, core of discipline, and transition to practice. Transition to discipline essentially includes 2 EPAs, one of which is a essential initial approach to any GIM patient, and would include a direct observation of a history and physical and initial assessment of a GIM patient. And the second one would be managing an unstable patient. And we would expect that both of these EPAs would be completed by the end of August 2018. And then Foundations of Discipline would be completed by the end of October. And then we would spend the rest of the year focusing on the coaching and assessing, of course, EPAs under Core of Discipline and Transition to Practice. We will make sure that you are that we direct you and make sure that you are on track to complete most of these EPAs, and we do not at all want to make this stressful or overwhelming for you. And as we will later go through the website, we have a plan of how to track you and make sure you understand what's going on. This is an example of a Cbme-Epa, as we discussed that this is a foundation one, where it is applying the GM approach to the assessment initial management of patients with any general internal medicine presentation in the acute care setting. These are the milestones associated under medical expert, communicator, collaborator, leader. And it is important that even though the bold milestones are listed under the EPA when you're completing an EPA assessment, you do not have to. This is not a checklist. This is it is not necessary that you are checked against each of these milestones to get to gain the trust of your assessor or attending. So these are more to guide the attending or the assessor to ensure that they know what the milestones construct the EPA. And if you are performing at a level of 3 or less on the entrustability scale, then the attending can use these milestones and choose 1 or 2 of these milestones to provide you specific feedback on where you could have done better. Again, emphasizing the point that the EPA assessments are low-stake assessments, which just give us, each of these EPA assessments would give us a brief snapshot of your competency level, and then would be used to be presented to the competence committee, which will then have the final decision whether you can progress to the next level, or if you need further EPA assessments and a learning plan. And those recommendations would be made to your academic coach, who will then ensure that you're on track and help you and mentor you in developing a learning plan, and essentially you would then be directed towards having other EPA assessments done and get coaching in the moment, which is when you're actually completing the EPA. Difference between coaching and feedback, which is actually the most important part of having your EPA assessment done, is actually getting that coaching advice or coaching feedback given to you at the end of your EPA assessment, which is feedback on not only what you did well and what you could have done better, but also actionable suggestions for improvement on how you could do better on performing that EPA. Direct observation will be a very important part of completing your EPAs, and it would be important to make sure that you can organize your time during your block to make sure that the EPAs that require direct observation, you can actually schedule a time which you're attending. Some of these opportunities would come on their own when, for example, if a patient is unstable and you're managing them and your attending happens to be there, they can observe you, and then you can spend 15 minutes afterwards completing an EPA assessment and getting coaching on that EPA. The EPA assessment itself with the coaching should not usually take more than 15 minutes, and this is in addition to either a case presentation or a case review or a direct observation, which you would have been, which an attending would have been doing anyways on your clinical rotation, and the EPA assessment just adds a protected 15 minutes on that, but it ensures that you have the opportunity to sit down with your attending and get coaching on specific EPAs to improve on them and move to the next level. Again, emphasizing that moving into this is a change in culture, and it is very important to have a change in mindset and develop a growth mindset, because at this level of PGY4s, we do not expect that most of you would be starting above a 1 or a 2 on the entrustability scale, because most of you would need some level, if not some level of supervision when you are performing an EPA. And this does not mean that you're performing poorly or that you would be a fail on an ITER. This does not equate to that. It just means that we think you need supervision, and we can work on how to make you more independent and be entrusted more with responsibility on responsibility, or managing these patients on your own, or managing and it would be important to therefore take each of these EPA assessments as a challenge and an opportunity to grow and get better at your competencies. We're just going to switch over here and actually discuss how we are going to